Thank you, Dr. Haripriya. And most of the things which I was planning to tell was told by Dr. Venkatesh. And so we'll show what he has told mostly. So this is just to start off in a lighter note, how to manage most easiest way of doing a capsule PCR management. See, an IOL has been placed and I just wash underneath and I see two lines here. Is it seen? So at this point the one haptic is here and the other haptic end is here. So this two lines on the PC, I could just leave it like that, Sometimes the end of the haptic may be on that side and it may later get decentered and others. So what can we do in this kind of situations? Any guesses on this? Yeah, but then what happened is I thought I'll just pull this. Then I see that it is not a PC rupture. These are two fibers of cortex which have got stuck to the haptic. So this is one of the easiest way I managed one of my supposedly PC rupture. So that is gone. So we'll go on to more serious stuff. So this is a plain straightforward looking cataract, clear corneal incision. And I'm doing a complete rhexis just to show that this is complete. Can you take this cursor off? Complete rhexis. Hydrodissection, epinucleus gone, and routine my burrow and chop technique. Happening, chop is going on. Pupil is becoming a little smaller. I don't bother because my central chop is going on fine and the pieces are getting separated. And now I take out one piece and the other piece is taken, made into a smaller piece. So almost one half of it is gone. Pupil has become relatively smaller. And I'm going for one more piece which was free, chopped. And that is finished. And now I try to rotate this nucleus a little bit. Now, and movement is not so very easy. So then I see one line here. Can everybody see this line? I could also see. So then I realized that there is something inside underneath the piece. So now I realized that this is sitting on a PC rupture. So but there is no vitreous right now. So I am, as Venkatesh said, I was thinking, but then I thought I'll continue doing a little more of it. So what I do is I go close to the nucleus piece, hold it, bring it up a little bit away from the PC ruptured area, do it very controlled, do it very slowly. This IP which is happening here helps me in controlling the emulsification. Now this is a large piece. So this is sitting right on top of the PC rupture. So anytime you shallow the chamber, you're going to get vitreous loss. And if you push it again, it is going to dip into the PC rent. So if you take out irrigation also, you're going to get shallow. So we have to very gently maneuver. Now one piece comes to me, welcome. So this is taken off. So, but then again, the problem is this big one sitting here. So this one is very gently moved. See, I have had nuclei going down, trying to move these kind of pieces. So being very careful not to shallow the chamber and to irritate this one too much. Rather than that, hold it a little bit, pick it up with both instruments, move it away, hold it on top of the iris which you have. There is another piece trying to go down away from me when I am concentrating on this, and somehow luckily it's still staying there. No vitreous loss till now. That is one great thing. Again, there is not much of movement of pieces, but there are small bits which cannot be controlled much. So some are sitting on top of the iris. So that is good for me. So again, you move it away from the area of PC rupture. Now you can see it much bigger. So it's very scary to look at. Again, this was a steady video till now. Now you can see that there is some bit of shake. Venkatesh said, be cool. Can't be cool. Adrenaline just comes. Adrenaline just comes. You can't control that. Hands keep shaking. So hands keep shaking, but suddenly nothing happens much, and this is controlled, and I always manage to keep it away and do a slight emulsification, and now it's gone. But adrenaline, once it comes inside, doesn't go off very fast. Although nucleus is gone, still I am trying to inflate the anterior chamber. This is the most crucial step. Do not withdraw. Inflate with viscoelastic. See the shake of my hand? It doesn't stay steady at all. But then somehow I managed to get viscoelastic inside. So HPMC, don't push too much of HPMC into this. Is dispersive viscoelastic. I'll take the name Viscoat. No financial interest on that, but still it is the one which does not cause much of a problem later on. And now see what happened. This was a rhexis tear which extended towards the periphery on the PC, and then I have managed to place and visualization, as Dr. Venkatesh said, put iris hooks, open up and see, and then identify what is wrong, and then I could successfully place a lens into the bag where there was enough PC support. Now, second case, does it look like a big posterior polar cataract to you? It did not to me. This is not a great posterior polar cataract. Hydrodissection did not happen. But I wouldn't stop. I kept on hydrodissecting from another side, till hydrodissection happened. God said don't do hydrodissection, but again I kept on doing. So hydrodissected fully. And then took out my epinucleus, my regular step, and then do a burrow and then start chopping. This is a horizontal chop, not very hard. So I do horizontal chop with this instrument, and I complete my first chop and then rotate fully. See, the rotation and the shear which happens along the posterior pole or cataract is the one which opens up the posterior capsule when you have posterior polar cataracts. If you lift it up, I will show you in the next video, if you do it gently, many posterior capsules which would have ruptured would not rupture in a posterior polar cataract. See, I am coolly doing, like ignorance is sometimes lucky and bliss and happiness. Nothing happens and I finished it fully. And I did not notice anything till I took out my probe. And I took out my probe and see a little clear area. And then I shallow it a little bit and I see an open BC. So sometimes you are very lucky. And sometimes because there is no vitreous disturbance happening and the nucleus is freely moving around, nothing much happens. Again here, because there is no vitreous disturbance, ideal thing would be to plug this area with dispersive viscoelastic. It doesn't get aspirated very fast. It blocks that area, and with low parameters, I am not low actually here, but then it is better to have a controlled aspiration and do not let it shallow. That is the dictum I keep telling again and again. And the last bit of this one, you can do a dry aspiration, or you can, as Dr. Venkatesh was telling, a bimanual, or I like my Simcoe, and you can go from another port, so that there is no, because this port is bigger. And then finally this patient had opted for a rigid lens, and so I place my rigid lens into the sulcus because there is a good rhexis. It remains very well there. The point is, whenever there is no vitreous disturbance, please fill up that area with dispersive viscoelastic, plug it, and then whenever you see it getting evacuated, put more viscoelastic. Maybe you will need one or two more. Here again, a mature cataract. This is the Chang's hydrodissection cannula, which is a specially made one. I keep hydrodissecting, which is not much required in a mature cataract. You do not need to do much of hydrodissection. So I do my chopping and then I try to rotate. It doesn't rotate. This is one sign. A rotating lens on either sides, clockwise or anti-clockwise, if it stops rotating, think that there is a dialysis or a rent with vitreous. So now my way to take it out will be, see, take out one piece from here, and because this is a very soft cataract, I can go around the equator of this. This is a blunt chopper. This is made by Indo-German 1769 model, and it goes around the edge of the equator, and you can tumble it little into the anterior chamber in the iris plane and bring it into the anterior chamber and do a phacoemulsification with a controlled phacoemulsification. And at any point of time when vitreous prolapses, there is another talk coming up. You should deal with the vitreous. And the second last piece, which was here, can be manipulated, lifted up. You can hold it with vacuum, use your second instrument from the side and pick it up, bring it into the center and do phaco rather than rotating. Now at the end of the phaco, I see that there is this is one line and this is one line. This is my PC opening, which is already there. So mature cataracts, remember, there could be open PCs. So this is my technique for posterior polars and open PCs. So you do the first chop and then do not rotate. Rather than that, this is not rotating. So then go to the side, turn towards the side, take out one pi of nucleus, finish it off, and then go underneath your rhexis here with your blunt chopper, go to the delineated nucleus margin and support the nucleus with your phaco probe, do another chop here, and then you get another pi free, and then you got a lot of space here. Now this half of nucleus can be lollipopped out. You can use the probe itself. This chopper can be used to mobilize it mechanically a little bit so that the equator is free. So you don't pull it very drastically, but then a little lift, because there is space here, can bring a part of the nucleus closer to your tip and then go in with vacuum, hold and lift it up and bring it into the anterior chamber or in the iris plane and phacoemulsify. At the end, the last piece again is speared out. I go in with my phaco probe, go in with phaco energy, stop, hold with vacuum, lift it out and bring it into the center without rotating. That is one thing which will not disturb your PC, which would otherwise open up if you have a posterior polar cataract sitting behind. Many of your mature cataracts, Indian population, people live with posterior polar cataracts and come to you with harder cataracts and mature cataracts, and finally this technique has helped me a lot to not to rotate a nucleus and complete a phacoemulsification in a posterior polar. And now, as Dr. Venkatesh was telling, this is a big rend which is sitting here. Now I know. So the viscode pal, what he said, I am showing now. This is our sclerotomy, just like your 3 mm posterior pars plana sclerotomy which you make. Go in, this is viscode going in, and viscode goes in. Remember, there should not be vitreous, and this nucleus should not be inside vitreous. If it is inside and it is mixed with vitreous, there is no point in doing this. This is an impending drop which is sitting on the AVF with a big poster capsule ruptured below. So if you want to mobilize this, go in, put viscode underneath this, it is trapped there, and then using the same cannula or even other spatula, you can pick it up and bring it into the anterior chamber, and then this case I have taken it out, and you can do a sheets glide phacoemulsification also. As Dr. Venkatesh was telling, once you have a PC rupture here, see, this is vitreous coming into your port. After that, don't try to emulsify. If you try to emulsify, again vitreous is going to come. So you won't be able to catch the red of the nucleus. So at that point, again put dispersive viscosity. This is another case. Last piece, again as we were telling, my parameters are not shown, but because of surge, I had a touch on the PC, and here the PC is open. So I am cool now. I know that there is a PC rupture. I need to put in viscode. Again viscode comes, and then my irrigation is on, and so AC is not shallowing. And again you cannot tell the patient that you have a PC rupture, don't shake your head. Patient suddenly shakes the head. Patient shakes this way, and I hold the head, and then comes back normal, my viscode is out, but my probe is not out. So probe, you anyway have to hold the probe very well, whatever happens, till you put in dispersive viscoelastic and plug this area, and then come out of the anterior chamber. And after that, assess the situation, assess the size of the rent, whether there is vitreous inside or not. Oral lab makes Orocoat, which does not have a preservative, and you can use the triamcinolone to stain this vitreous also, and then confirm. You can take it out this way, because there is a last very small piece. I just extended till 4 millimeters, and I could take it out. And the sheet glide thing is also a very good idea, to place it inside and do a phacoemulsion. And at the end, sometimes nuclei just drop like this. And if it is in the anterior vitreous and below, don't try to do, that's not your day. You to call your vitreous consultant and treat it appropriately. Thank you very much.